when there is a relapse and you're treating, you're trying to get back to that, you're trying to recover more quickly, you want to get a patient back to their baseline, those are our goals, and you've exhausted the IV solu-medrol. How do we know what to do next? What data do we have? Is there any research that's going on? Specifically, I think there was a poster at ACTRIMS also that looked at those patients who had failed, or I should probably say IV solu-medrol, the traditional dose, had failed them in the treatment of their relapse.
Right, so that's another trial that I'm involved with, which is basically the study design of the randomized double-blind placebo-controlled option study of repository corticotropin injection, which is Acthar, for the acute exacerbation of relapsing-remitting multiple sclerosis. And then this study is from multi-centered out of Cincinnati and Mount Sinai. But basically, what this trial is this is for individuals who had an incomplete recovery from IV methylprednisolone for 3 to 5 days, for oral prednisone 1,250 milligrams per day, or oral methylprednisolone for 1,000 milligrams per day, again also for 3 to 5 days. And if the patient did not have a greater or equal to 1 point improvement in greater than or equal to 1 functional system, at 14 days, then they are being randomized to either subcutaneous RCI or Acthar 80 units for a period of 14 days, or a matching placebo for 14 days. So at first, I'll be honest with you, I had a little bit of some reservations about this study because of the placebo end of it, but the fact that most patients naturally wind up on the placebo end of it, because most MS physicians or most general neurologists, after a patient receives their typical treatment of IV methylprednisolone or high-dose oral steroids, if they don't respond, they figure this is as good as it's going to get. Mm-hmm. And so what this study is showing us, no, why don't we give the patient 14 additional days of treatment and see what occurs? Now, we do not have results yet from this trial. I mean, basically, we are still placing patients in the trial and randomizing them, but I am very much eagerly awaiting the results of this trial, because I'm confident, but again, we have to be careful with those words in medicine, but I'm hopeful that it will show that this is a very good alternative for patients who do not respond well to initial treatment.
Do you think there's something about the patient's biology that keeps them from improving on IV solu-medrol, or needs another alternative, maybe on the basis of those melanocortin receptors you mentioned, just hypothetically?
Right. I think that basically, patients who have a little bit older, I think don't respond quite as well. I think patients that have highly active disease a lot of times will not respond as well. The patients that I have who really do extremely well with IV solu-medrol are usually my patients who have less active disease. And so when I put patients, when these people are placed on IV solu-medrol, they get a big response from it. Not only do they sometimes get a good response clinically, they actually feel well on the medication. They talk to me about, they love their steroids because they got everything cleaned in their house that they haven't gotten done in a long time. But my patients who have highly active disease, my more difficult to treat patients, and my older patients, I have found a lot of times that they really can struggle with side effects from the IV solu-medrol, and also just do not get as good of a response.
Yeah. So your expectations out of this trial are, you want to see if there's efficacy there, and again, it's a real world setting, right? These are patients
right.
that are from our clinical practices. So, yeah.
Exactly, and I really do think that my expectation is it is going to show that there is a clinical difference in the end with this trial, because I do think that patients will improve both from the patient-reported outcome portion of it and the clinical examination portion of it by the physician.